Okay, so what I'm going to be doing in this video is just giving a brief overview of upper limb anatomy. So you can watch this video just before you actually start learning upper limb anatomy, so it gives you a bit of an idea of what's going on, gives you a bit of an orientation, and then also just for the exams, you need a quick recap as well. I'm not going to be doing this like upper limb anatomy in detail. Here is like a couple of good anatomy resources that I find. So Teach Me Anatomy, Ken Hub, two examples of websites with just like loads of really detailed information on anatomy. Go there if you want like actual good detail in terms of like the origins, insertions of muscles, etc. Sam Webster, I think, is a really good YouTube channel. He just explains like using different models and like explains anatomy in quite a cool way. So actually, yeah, what I'm going to do is just like a quick overview. The way I'll be doing it is a brief intro into anatomical language. It just helps in terms of understanding the different names of muscles and what's going on. So I think that's a very important place to start. And then I'll just actually get onto the upper limb anatomy, so going through bones, blood vessels, muscles, and nerves. I'll be going through it like actually in that go, so all of the bones in the upper limb first, then all of the blood vessels, then all the muscles, all the nerves. I'm not covering everything, just key points and then a few memory aid techniques that I find quite helpful, or other people I've heard have found quite helpful. So yeah, it's not going to be detailed. Okay, so we'll get into it. So anatomical language, so you've got 3 different axes. This is quite important. You've got sagittal, coronal, transverse. Get very familiar, and like whenever you're looking at any kind of anatomical image, try and think about what axes, like what plane of axes is this image in. Is it sagittal, is it coronal, is it transverse? Because this is going to be really helpful when you're looking at different scans, so looking at x-rays, MRIs, CT scans, any other scans you can think of as well. Yeah, so going through it. So sagittal here, that would be this one, like the yellow shaped one. Basically, what this is, think of sagittal as Sagittarius. It's the archer. So think of somebody as shooting an arrow straight through you, like that. That's the direction of the sagittal plane. Then you've got the coronal plane, which is this blue one here. And a lot of people talk about it as, oh, you're putting a crown, so coronal crown, putting it on your head that way. The way I think about it is, you got coronal sounds like coronavirus. It affects your nose. So which direction, if you're trying to cut off your nose, it's going down this way like that. So that's the direction of the coronal plane. And the next one, transverse plane, like this red one. That's basically cutting across. It's a transverse cut across. So you can be getting it all the way through here, and you'll be looking at those different levels. Sagittal, you'll be cutting it like this, and then coronal, cutting it like that. Looks the same as transverse, but you know what I mean. Okay, so going on to the next set of definitions. One of the things that's important to mention at this point is the anatomical position. So you see this person here, they are in the anatomical position. Where's the anatomical position? Standing up straight, hands at your side, palms facing forward. So palms facing forward, and also feet facing straight on as well. Can't see his feet, but like that's not a great drawing, but yeah. Yeah, so this is the anatomical position. Whenever you're talking about any kind of movement or anything, you always start in anatomical position and then describe the movement from there. Okay, so anterior versus posterior. Let's go through this one. So anterior means front, posterior means back. So a good way to look at this is using the coronal plane, this one here. So this part of the body here is the front, so that's the anterior. You can't see behind the coronal plane, that would be the posterior. Ventral dorsal, ventral front, dorsal back, same thing. Proximal distal, proximal near, distal far, so shoulder is more proximal than the hand. Proximal proximity to people, how close you are. Distal, distance, further away. Medial, lateral. Okay, medial, you've got the midline, and then medial, however close it is to the midline, so like there. Lateral, how far away it is, here. So, for example, this part of the arm is more lateral than this part of the arm. Next one is superior versus inferior, superior top. So, superior and then inferior. The shoulder is more superior than the hand. Cranial versus caudal. Cranial, head, cranium, here. Caudal meaning tail, there. You might have come across this word in embryology, rostral. What does that mean? So you might have had the rostral caudal axes. The way that I remember it, so caudal sounds like tail, so you'll hear of a disease called cauda equina. So it's like the horse's tail, it's the end part of the spinal cord that's compressed. So then rostral, caudal, rostral rhymes with nostril, so the nostril is in the head. So then that means that the rostral is like higher up basically. Internal versus external, internal kind of meaning deep, external, superficial. I think that's fairly self-explanatory. So the liver is more deep, it's more internal than the skin, for example. Okay, so now moving on to these ones. What you've got is flexion versus extension. So flexion, if you think about, if you bend at your elbow, you lift your wrist up to your shoulder. What you're doing is you're reducing the joint angle. So that would be, flexion is reducing the joint angle. So that would be flexion of the arm. And then extension is the opposite. So always learn these definitions as opposites. So it then just makes it easier learning it. Extension is then straightening out your arm. Abduction versus adduction. Abduction, taking away. If an alien comes to Earth and they abduct you, they are taking you away from Earth. Adduction is therefore the opposite. So it's bringing closer. So in terms of your arm, so here's the midline, right? If I keep midline, actually if I just draw a midline there, if this person moves their arm out that way, so they're moving it out from their body, that would be abduction, they're taking it away. If they now bring it in that way, that would be adduction. But yeah. Okay, so the next one, medial rotation versus lateral rotation. Go back to anatomical position. We will look at, if you put your arm out like that to the side, if we go with the rotation, we'll use your thumb as the reference point. Medial rotation, if you think of your thumb, try pointing it forward now. So your thumb goes from this outwards position to kind of like facing forward, like that. That is medial, you're rotating your hand inside, right? If that makes sense. Lateral rotation, your thumb, now try moving it back. That will be rotating it outwards. So away from like external rotation versus internal rotation. Pronation versus supination. So this is basically like if you think flipping your hand, for example. So this one. So you're flipping it back and forward. I remember it. Pronation is like you're lying on your stomach, and then supination is you're lying on your back. So supination, how do you carry soup? You keep your hands up so you can carry a bowl of soup. Pronation is therefore the opposite. Inversion, eversion. This is like a movement to describe movement of the foot. So inversion is you have the sole of your foot facing in towards the midline, and then eversion, bit uncomfortable, you have the sole of your foot trying to face outwards. Circumduction, it's like a combination of many of these different movements. Think of it as like your shoulder joint, for example. Like it just does a whole bunch of movements, kind of moves in a circle. Deviation of the wrist. So this one's an interesting one. Deviation of the wrist, you might come across it being described with abduction, adduction. So have your hand out at the side like this. If you now move your hand outwards, this direction, but just at your wrist, that would be radial deviation, because your radius is on the side of your thumb, and so you're pointing it outwards to the side of the radius. That might also be called wrist abduction, abduction. the opposite then is on the deviation. So this is the other side, so you're pointing it more to the midline, so you're pointing it that way. That might be called wrist adduction, a deduction. You need to really understand these, otherwise it's going to make learning anatomy quite difficult. A lot of these words like flexion, extension, these words are used to describe muscles and actually what they do. So if you understand what they do, it makes learning anatomy a lot easier than if you don't understand what they do. Okay, a lot of people get confused with joints, so I'll really quickly run over this, but don't worry too much about it. Okay, so you've got 3 different types of joints: fibrous, cartilaginous, and synovial. Fibrous joints basically don't move. Don't worry too much about them. Example, sutures in your skull. Each of the bones in your skull are joined by these things called sutures. They are types of joints. You really don't want them to move, so they basically don't move. Yeah, that's basically what we need to really know about fibrous joints. The next is cartilaginous. All of these 3 categories just describe how much movement the joint can do. Fibrous basically don't move, cartilaginous move a bit more, synovial, they move quite a bit. Cartilaginous, so for example the pubic symphysis there, a little bit of movement, but not a crazy amount of movement. Okay, then you've got synovial. These are basically what you think of when someone says, if they think of a joint, so whether it's the elbow joint or the shoulder joint. So the shoulder joint is an example of a ball and socket joint. These are the examples of synovial joints. Best way I think to learn them, find the YouTube video where you actually see someone doing the movement. It makes it a lot easier to actually understand and actually visualize what's going on. Also do it yourself. Same with these movements, do it yourself. Actually on yourself, move to actually kind of experience what's going on. Oh, and here's just the different types of joints. Okay, don't really worry about these different words too much. Try getting basic understanding first and then build up from there. Okay, let's actually start with a brief overview of upper limb anatomy, which is basically what this video is about. So, what you got is this picture here and this picture here, pictures of the arm. This is the front of the arm, this is the back of the arm. Here you've got something called the shoulder. Here you've got the arm. This is actually a very important point. All of this is not called the arm. Only this bit is called the arm. This bit has a different name. This bit is called the forearm. This bit is called the hand. Okay, so that's your brief kind of understanding of what's going on, and it's the exact same on the back of the hand. So there, and there. I'm not going to label it. Yeah, points of interest, I guess, going green. Here, this bit is called the cubital fossa. Cubital fossa. If you're going to have a blood test, probably put the needle in there. We'll discuss later on why they put the needle there. It's basically because you'll get a vein, but you won't hit an artery. And you're going to take blood tests from a vein, not an artery, because if you hit an artery, there's a lot of blood's coming out. And that's not good. The reason why you're not going to hit an artery is because all the arteries got under there will go under this structure called the bicipital aponeurosis. So that's like this fibrous structure that is very difficult to actually pass. You're never going to pass the needle through the bicipital aponeurosis. So it protects the arteries while the veins are superficial. The next structure is this one here. This is called the wrist. So the wrist, the reason why it's something of importance is you might have heard of a disease called carpal tunnel syndrome. So the wrist is made up of bones called carpal bones. Carpal bones. I realised I probably didn't choose a great colour. Carpal bones. We'll go into them. But yeah, you've got this thing called carpal tunnel syndrome. You've got this another structure that basically goes over it, and then if it gets compressed, it compresses on the median nerve, and that leads to symptoms of carpal tunnel syndrome. Then you've got these bones here. So if these are called the carpal bones, these are called the metacarpal bones. Then the fingers are called the phalanges. So your toes and your fingers are both called phalanges. The bones in your hand are called the carpal or the metacarpal bones. So carpal is the main point there. In your feet, they're called the metatarsals. So tarsal with a T and then carpal with a C. The way to tell the difference is tarsal toes. That's obviously going to be a foot. Carpal, think of it as if you're trying to catch a tennis ball, you catch it with your hands. So carpal bones in your hands. This thing is called the elbow. The medical, fancy, anatomical way of saying that is olecranon. And in terms of just as like a brief overview, oh yeah, there's one thing else. Just kind of here, you can't really see it, but we'll get into it later. There's this thing called the anatomical snuff box. It's called that because of the shape it makes at the base of your thumb. If you like try, you could do it now. You can actually extend your thumb back as much as you can, and you'll see kind of like these two lines will appear, and this like indentation near to your wrist, like around there. That is called your anatomical snuff box. The reason it's called that, I think it's like the French, but like it's like used to snort to like tobacco or something, like tobacco powder. I don't know, read the Wikipedia page on that if you want. But yeah, so that's called the anatomical snuff box. We'll get into that later. This is just a good clinical landmark. Okay, let's get into the actual skeletal system now. So, got the arm. Let's actually now label the different bones. So here, this one is called the clavicle. This one here is called the scapula. Clavicle being the collarbone. So this would then articulate with the manubrium, which then has like the sternum, and that's got then like xiphoid process. I'm not going to go into all of that, but that's just like a brief idea, and obviously symmetrical same on the other side, so you'll get another clavicle going that way. But yeah, then you've got the scapula, that's on the back. Then you've got this bone here, which is called humerus. Then you've got these two bones. So one of them's probably going to be the radius, one of them's going to be the ulnar. How do you tell the difference? Well, if you're taking the pulse at your wrist, so around here, right, that's called your radial pulse. So then that's the side nearer to your thumb. And if this is your thumb, then that means this one is then the radius, which makes the other one the ulnar. You'll be able to tell the difference between the radius and the ulnar just by looking at the different bones. So for example, the radius has a round head there, and that allows for like when you pronate, supinate your arm, that's going to be rotating within this structure called the annular ligament. We'll get into that later as well. But yeah, the other thing with the radius and the ulnar is the shape of them. So the ulnar starts off quite big and then gets thinner. So it looks that kind of shape, while the radius starts off thin and then gets bigger that way. So if that's the radius and then that's then the ulnar, so it kind of fits there, and that's why your arm kind of looks straight. The ulnar has that's what you're feeling. If you're feeling the elbow, that's the olecranon process. So that'll be on the back, kind of behind there. Obviously this is the front view, so you can't see at the back. But yeah, so that's basically what's going on there. You're obviously then going to have different ligaments and stuff all about, but don't worry too much. Next thing is these bones here. These are called the carpal bones. That's what makes up the wrist. And you can see, obviously, okay, the radius here has a much bigger surface area of contact than the ulnar. That's why the radius will be articulating more with the carpal bones. Okay, so then if you've got the carpal bones, then you've got here, which is the metacarpal bones. And here is the phalanges. Okay, so that's basically just an overview of the different bones. Let's go on to looking at it in slightly more detail, just slightly bigger as well. Okay, so what this is called, let's go with blue. This is the scapula. So this view versus this view, the difference is this one, think of it as looking at someone's back, and then you're like looking through their skin and you're seeing their scapula. So this is actually their back. This view here is you're looking at someone front on, so you're facing them, and then you're looking through their rib cage, through their lungs, and then you're seeing this structure, which is a scapula. Hope that makes sense. So this is basically what I'm trying to describe as posterior view, anterior view. So hope that makes sense. Okay. So when you look at it, it kind of looks triangular in like shape, right? It's got, if we just draw lines like that, you've got a medial border, lateral border, and then an upper border. That then describes a triangular shape. So the same here, here, and here. Yeah, those are the borders of the scapula. Okay, next thing is you've got kind of three key areas of the scapula. You've got this one here, and this one here. So I'm just going to draw another line here like that. What's going on is this bit here and this bit here have two different names. This one is called the suprascapular fossa, and this one is called the supraspinous fossa, and infraspinous fossa. And the reason why they're called that is because of this red line here. That is the spine of the scapula. So it's dividing supra, meaning above, infra, meaning below. So, and fossa kind of means hole. So you got the supra and infraspinous fossas. And then here, you've got the subscapular fossa. So now this is like looking through the person's rib cages and everything. So if I just kind of label that for you. So this one here is called the supraspinous. This one is called the infraspinous. This one is called the subscapular fossa. And the reason why it's supra and infraspinous is because of this thing here called the spine of the scapula. So if you actually feel on your back, straight across, you can actually feel the spine of your scapula. And then you just know then below that will be infraspinous and above that will be supraspinous. You're not just feeling holes, obviously, like it feels not as hard as bone above or below there. That's because the muscles sit there. Again, we'll get into that later. The other thing with the scapula, I'm just going to clear all of this stuff to get a better view. There are these two structures. So this one here, here and here. Okay, obviously you're just getting them from different views. So they are called the acromion and the coracoid process. Coracoid. Okay, so which one's which? Coracoid is like crow's beak. Don't know why it's called that. I guess it's supposed to look like it. That's this one. And then the acromion is what you kind of feel like. If you feel your shoulder joint, that kind of like knobbly bit, that is your acromion. So that's there. So this one here is the coracoid and this one here is the acromion. Good sites of landmarks in terms of like surface anatomy and like feeling where things are. The other thing is, I'm not going to go into it, but there are different ligaments that you've got kind of between all of these structures. You just kind of got to learn them. But yeah, best way to learn it is find an image and just learn it. The other thing, okay, yeah, actually you can kind of see it. So you see this bit, it's kind of hidden, but as in like it kind of goes around like that. There. Okay, yeah, this bit. That is called the glenoid fossa, or glenoid cavity. So that is where it's going to articulate, the scapula is going to articulate with the humerus. What that's called, that is the ball and socket joint of the shoulder. That's called the glenohumeral joint. So glenoid, because of the glenoid cavity, and then humeral, obviously the humerus. So that forms the glenohumeral cavity. You've also got this thing with the shoulder joint. It's really easy to get shoulder dislocations because it's actually a very unstable joint. Because this actually, even if you look at it, right, it looks fairly flat, but you know that there's got to be some kind of curvature to it. There is a curvature, but it's quite shallow. It's not as deep as, for example, in your hip joint. That's also a ball and socket joint, but you're less likely to get a dislocation of your hip joint than you are a shoulder joint, just because of how, the deepness of the actual glenoid cavity. Because of that, you then need different structures in support of the shoulder joint. So, for example, like the rotator cuff muscles, they kind of stabilize the shoulder joint. And yeah. Anything else about that? Oh, there's a structure called the glenoid labrum, which tries to almost, the way that people describe it is, think of it as a trench, the glenoid cavity as a trench, and then you put sandbags up on the side. Technically, the actual depth of the trench is exactly the same, but because you now put sandbags up, it makes the trench look deeper. That's kind of what the glenoid labrum does. Yeah, so that's basically the shoulder joint. The other thing, so if I kind of roughly draw, that's the humerus. But yeah, you've got this thing called bursa. So these are kind of these fluid-filled sacs that kind of are placed all around the shoulder joint. You can get this disease called bursitis, which is inflammation of the bursa. And so what the bursa is supposed to do is it reduces friction between the ligaments, the tendons, and the muscles. So it just allows it to move smoother. Obviously, if it then gets inflamed, i.e. bursitis, the itis being inflammation, it then hurts. But yeah. Okay, going on to this picture. So this is obviously then, you've got the humerus, and you then got this bone and this bone. How do you tell the difference? Well, kind of got to look at it. What did I say before? I think I said this, but as in this bit here, one bone goes like this, and one bone goes like this. The ulna is the one that's bigger at the top and smaller at the bottom, and the radius is the one that's smaller at the top and bigger at the bottom. So then that means this one is then the radius, this one is then the ulna. Also here, head of the radius is round for rotation. But let's get back to the humerus. The thing with the humerus is there's in terms of different kind of clinical diseases, you've got the anatomical and surgical neck. So there's one here and there's one here. So which one's which? The top one is the anatomical and this one is the surgical neck. What's the difference? Well, actually, if you look at it, here you've got the head of the humerus. It's actually just a lot thicker. So there's more bone, it's harder to break. Here, it's a lot thinner. So that's why the surgical neck is easier to break. That's basically the difference between anatomical and surgical neck. You can get more breaks in the surgical neck than you are in the anatomical neck of the humerus. Anything else with it? Oh yeah, you've got just like different things here. So what these supposed lines are called collateral ligaments. So you got the ulnar collateral ligament, UCL, and then the radial collateral ligament. They just kind of stabilize the arm so it doesn't go out at a weird angle. It allows for the hinge joint to work well. Then the next thing, so what they're attached to, if I just get rid of them, these knobbly bits, if you actually feel on your arm around the cubital fossa, you feel these two knobbly bits, right? On the medial side, it's called the medial epicondyle. On the lateral side, it's called the lateral epicondyle. You might have heard, if these get like inflamed or anything, people talking about tennis elbow versus golfer's elbow. So tennis elbow is for the lateral epicondyle is inflamed, so lateral epicondylitis, and golfer's elbow is the medial epicondylitis. I don't play tennis or golf, but the way I think about it is, for example, if someone's going for a backhand in tennis, the lateral epicondyle will be facing the ball, so that's the one that's going to get inflamed. And then with golf, if someone with a club is going to hit the ball, for example, I'm right-handed, then my medial epicondyle will be facing the ball. If anyone plays the sport and that's wrong, I don't know. But yeah, that's the way I remember it. I think it's called bad technique or something. But yeah. Okay, so I don't know if I said this before, but the ulna has, like, when you're feeling your elbow, that's what you're feeling, the ulna, which means that then when you're moving and like flexing and extending your arm, that has like that bony part, the elbow's got to go somewhere. That's actually fitting into the humerus, so that's called the olecranon fossa that you're actually like moving your arm into. Like another cool trick, so we haven't really covered this yet, but you'll get different breaks, like for example there and there. The way I remember this is just by arm. This is kind of works most of the time. Which nerve is going to get affected? So here, if it's at the top, the axillary. Here, radial, if it's a mid-shaft fracture. And at the bottom, medial nerve, median nerve. So yeah, just remember arm going down the humerus, about which nerve is going to get affected. Yeah, okay, that's basically everything I want to say with the humerus. You've got different like tubercles and sort of like whether it's the greater, lesser tubercle, and then like, you know, different grooves, like deltoid groove and whatever, but I'm not really going to go into that. You can look that up yourself. Okay, so with the ulna and the radius, you've got this kind of sheet in between, like that. That's called the interosseous membrane. That means then you've got interosseous arteries, and so then that's got like holes. It basically just keeps the bones together. Yeah. So that's ulnar, radius. Ulnar, radius. Here, okay. So I said here you've got the ulnar collateral and radial collateral. You've got this other thing here called the annular ligament. This is quite interesting, like it's of clinical relevance. So, yeah. If I just tried doing like a really rubbish drawing of the humerus, and then I'm just going to ignore the ulna, and I'm going to draw the radius. Okay, there's the radius. This is the annular ligament, this bit. Annular ligament. Okay, so here I've drawn the head of the radius is a bit wider like that. This would be for an adult. And you can see then that the shape of the annular ligament is kind of cone shaped like that. The reason why is because the head of the radius has grown out and actually grown into the annular ligament. What happens when you're still growing, if I draw another one, that's then your radius, and your annular ligament's exactly the same, but you can see the difference in an adult versus a child. The annular ligament is cone-shaped versus straight. So cone versus straight. You might have heard never pull, don't pull on a child's hand, for example, if you're like holding their hand or anything. Don't, and this is the reason why, because you'll dislocate their arm. What you'll do is you'll be pulling their radius out of the annular ligament, so it's a dislocation. So yeah, don't pull a child's arm, ever. And that's why, obviously, their bones will grow, and the head of their radius will then eventually grow, and then it'll kind of change, the annular ligament will then become more cone-shaped. But yeah, that's basically why you don't pull a child's arm. Okay, go on to the next bit. So now we're going on to the hand. Okay, so here, let's do a different colour. Go this one. So it's the hand. So if we just divide up the different components, okay, so what do we say this one was? This is the carpal bones. This one is the metacarpal. This one is the phalanges. Okay, that's basically the way that you're going to divide them up. So when you're feeling, for example, the bones in your hand, i.e. actually like where your palm is, that's the metacarpals. If you're feeling your wrist, all of those bones in there, carpal bones. If you're feeling your fingers, phalanges. And this is obviously your thumb. When counting your fingers, the way you count is your thumb is the first one, your index finger is the second one, your middle finger is the third one, your ring finger is the fourth one, and your pinky is the fifth one. So you always start counting that way. Next thing to talk about, okay, these carpal bones, I've quickly labelled them like this. We'll just go through them. So there is a bit of like a mnemonic to remember them, but we'll go through it first because it looks like a bit of a mess. Okay, so we'll just write out here. And then, okay, so the first one here, this is at the base, this is, think of it as kind of two rows, and it divides there and there. So you've got two rows kind of carpal bones, and then you get into the metacarpals. So the first one, A, is called the scaphoid bone. Scaphoid. The second one, so B, which is here, is called the lunate. C is called triquetrum. D is called pisiform. E, so now going up to here, and on with this like little flick there, it's called the hamate, so hook of the hamate. That is relevant later, and we'll talk about it when we get to carpal tunnel syndrome. F is called the captate. G and H are a bit confusing because they both begin with T. So G is called the trapezoid. And then H is called the trapezium. Okay, so the way to remember these, if we just go along this way and then that way. So if you start off at your thumb, base of your thumb, and just remember the phrase kind of, so long the pinky, here comes the thumb. So so long the pinky, here comes the thumb. That way, then that way. That's just a way to remember the order of the carpal bones. And it kind of tells you, yeah, just the order of them. Okay, next thing to kind of talk about then, if we then move up to the next stage, let's choose a different colour like this. Okay, so if I just draw lines randomly now, you got one line here and one line there. So the first line, if you've got, these are called the carpal bones and these are called the metacarpal bones. You have to have joints as well, right? So if it's called carpal and metacarpal, then the joints between them will be called the carpo-metacarpal joint. Carpo-metacarpal joint. If then these ones are called the metacarpals, these are called the phalanges, and these would be the metacarpophalangeal joint. So that's basically dividing up how that's going to go. And also there as well, metacarpophalangeal joint. Yeah, and there's the thumb. So then, okay, then you've got the, go different again, okay here. Then you've got the phalanges. You've got joints kind of here, and joints there. Go with this one. If we first label the bones, okay, so remembering proximal, distal, which one's kind of nearer, which one's far. Proximal, closer, like proximity. So these are then proximal phalangeal bones. And then these ones will be the distal because it's far. And so then you've got these middle ones, right, just in the middle. So let's call them middle phalangeal bones. Okay, so now that we've actually got these things labelled, we can actually make it makes it a lot easier in terms of figuring out how to label the joints. So this one here, let's call this PIP. So proximal interphalangeal joints. Interphalangeal because it's between the phalanges. Then this one, if this is proximal, this will be then distal interphalangeal joint. And so that's that. Now you're probably thinking, well, the thumb would only have a proximal and a distal bone. So then that means you just call this joint interphalangeal joint, because there is no third bone in the thumb. Yeah. So that is basically the bones of the hand. Okay. So we will now go on to blood vessels of the upper limb. Makes sense to do it in red, seeing as we're starting on arteries. Okay, so I'm going to start basically, where does blood originate from? The heart, right? The heart is going to be pumping blood around. So there's your heart. It's really bad drawing. Then what's going to come up? Got the aorta. Then aorta has like these 3 spikes or something coming out of them. So let's draw it at like 1, 2, and 3. So if we label them, we'll start off with the middle one, because why not? This is called the left common carotid. Then you got this one here, which is called the left subclavian. And this one is called the brachiocephalic trunk. There is this is one of the asymmetries of the body, where it's not exactly the same on either side, because the brachiocephalic trunk then divides like that to the right common carotid and the right subclavian. It's not great, but yeah, that's all first year content about the heart. So now, okay, so you can see then these ones are going up. That's going to be then supplying the head. These ones go out to the side. So they're going to supply the things that come off the side of your body. Your arms. Brachiocephalic trunk is just like this middle in-between gap. Don't know why it's there. Yeah. Okay, so that's basically, we're going to continue the journey of the arteries going through the arms. So we're going to just continue off with subclavian arteries. So I'm just going to get rid of all of this. But hopefully that orientated you of what's kind of going on. Okay, so subclavian artery. Let's draw that here. Then you're going to go to the next thing, which is the axillary artery. Which is like that. Obviously, if the heart's kind of like here, it's going to be going there, but I've only got part of the picture. Okay, so yeah. You've then got the subclavian to the axillary, which is there. Then after the axillary, what you're going to get is the brachial artery. Let's go to like there. So that order is very important. Subclavian to axillary to brachial. Reason why is obviously then, you'll see later, the veins normally in general follow the same pathway as arteries. There is a bit of difference, and we'll go into that difference, where you've got these things called the basilic and cephalic veins, but you'll still have like brachial, axillary, subclavian veins. So yeah, that's the order. Subclavian, axillary, brachial, SAB. Yeah, so then the brachial then divides like this. Okay, this now, you'll have, for example, if you're taking someone's pulse, like when you're doing blood pressure, what you'll be doing is you can put your stethoscope there. You're putting it on the brachial artery. You're feeling, for example, for the brachial artery, that kind of pulse I feel, the brachial artery. Another pulse we said is the radial artery. So that will be here. So that's what's dividing. Brachial divides into radial and ulnar. So radial and ulnar. And then, so that's there, that's there. After the radial and the ulnar, it kind of basically goes down to the hand. If you look at a picture of the blood supply of the hand, it looks very, very, very confusing. That's because it kind of is. But you don't really need to learn all of it, and most of it actually is kind of just name the same thing. So it's actually not that bad. But yeah, so if we go from this is also not a complete picture. This is like the main general supply. You will be getting a whole bunch of arteries kind of coming off and doing all kind of madness. So for example, here you might be getting a humeral circumflex artery around the axillary, for example, and that wraps around the humerus bone. Another thing you might be getting is, remember how I said there was the interosseous membrane? You then have interosseous arteries, so like anterior and posterior interosseous arteries. You'll get like different kinds of collateral, like ulnar and radial collaterals, profunda brachii, and like just different other branches that you'll come across. Don't worry about them right now. So, okay, after the radial and the ulnar arteries, what you're going to have is, got here, okay, so I'm just going to draw some random lines again. Okay, just draw those three. So, if we just zoom in, okay, this one, so the Latin for thumb is pollicis. So this artery is princeps pollicis artery. So that's supplying the thumb. That's branching off the radial artery. You also then have the index finger, because it's just super important. The radialis indices. That's then going to show that it's coming from the radial artery, and it's for the index finger. And then this other random line I kind of drew there, that is called the deep palmar arch. So there's a deep palmar arch, palmar, i.e. the palm of your hand, and it's deep, i.e. it's not near to the surface. That means there must be a superficial palmar arch. That's this one. That's coming off the ulnar artery. So, the ulnar artery was the one with the common interosseous arteries. But yeah, so the ulnar artery has then this superficial palmar arch. What then happens with that is then that goes, kind of just does a bunch of divisions to form the common digital arteries. Common digital. And then that then does kind of more divisions, I guess, for the proper palmar digital arteries. Yeah, so basically that's how it kind of divides. So subclavian to axillary to brachial. Brachial then divides into the radial and the ulnar. The radial supplies then, if you actually look at your arm, where you're going to be taking your radial pulse from, if you kind of draw a dividing line, you know it's going to be supplying the index finger and the thumb, and on the other side it's going to be supplied by the ulnar, the arteries, which is like you have then the superficial and deep palmar arches, and then you're going to get a whole bunch of different anastomoses, which is basically just kind of like joinings, I guess is the best way of describing it. The reason why is, think about how much you move your hand. If you, for example, slightly blocked one artery, you don't want then part of your finger to not be receiving any blood supply. So by having different anastomoses, it just allows for a constant supply to your hands. Hands are quite important. Yeah. Okay, so I think that's all right, I think, in terms of arteries. Yeah. Okay, go on to veins. Veins obviously have to be blue. Yeah, okay. So, let's now continue where we left off. You've got the heart. The heart here goes basically down here. With the whole point of blood, give oxygen. It's now dropped off oxygen even to the tips of your fingers. But now it's got to get back. So we will continue off from the tips of your fingers. So it gets a little bit confusing starting this way, but for the sake of the story, we'll do it and then we'll work the other way back round, and then just choose which one you prefer. But yeah, okay. So you've got then the kind of tips of your fingers. Blood has then been used up, and now you need to get it back. So you've then got kind of veins going up like that. These would then be the palmar digital veins. Okay, let's call them palmar digital veins. Then here, like this, they then travel back up to the palmar metacarpal veins. Okay, from the palmar metacarpal veins, I'm just going to draw a line up here, and that is going to be the medial antebrachial vein. Medial anterior brachial vein. And so then this is the bit, so I'm just going to draw like this and that, so it kind of makes like a Y shape, and then I'll get back into that later. This vein here, there's going to be some kind of different anatomical differences between different people, This is the benefit of studying anatomy from a textbook. All human bodies appear exactly the same in a textbook because you're only looking at one image. But for example, when you get to dissection, you'll see that each kind of body is different, and then not everything's exactly the same. So this is one of the things where it might be a bit different again. But yeah, so this one is called the medial cubital vein. That is the vein where blood is taken from in a blood test. And so then under that, you put your needle in. Actually, if I just maybe draw it out. Okay, so here's your vein. Here is your needle, like that. Then I'm going to draw a sheet like that, and then arteries under there. Okay, so what you got here, needle, vein, this thing, and then an artery. You put your needle in there, bevel facing up, and what happens is you then get your blood flowing in and you collect your blood sample. Let's say now you've pierced straight through the vein into there. Is there a risk that you're going to hit into the artery and then loads of blood loss is going to occur if you take blood from the cubital fossa? It's unlikely because of this structure here. This is called the bicipital aponeuroses. Bicipital aponeuroses. Basically, this is like a sheet kind of thing coming from the biceps tendon, and it just divides between the veins and the arteries, things like brachial artery. So you're not going to be piercing the brachial artery, and it means that it's a pretty safe place to be taking blood from. So that's why take blood from the cubital fossa. Yeah, let's just get rid of this then. Okay, so now going back to then the medial cubital vein, this then leads up back into the same kind of order as these ones, but going in reverse. So we're just going to stop here at this level for a second, and then we're going to loop back around. Let's go blue again. Okay, so remember you got the palm of your hand is the front of your hand, so you feel your palm, and then the back is called the dorsum of the hand. So if I go like this now, like this. Okay, so what I've drawn here is on the dorsum of the hand. So here you've got the dorsal digital veins of the hand, dorsal digital veins of the hand. Here you've then got the dorsal metacarpal veins. And from there, you've got this kind of structure here. This is called the dorsal venous network. So this is, if you look at your hand, you can kind of see an archway kind of thing. This is the dorsal venous network. Yeah, so that's there. Okay, so then this kind of divides into now two different veins, which I was talking about earlier. So the basilic and the cephalic or cephalic vein, don't know how to pronounce it. And you then have two things. Which way around does it go? The way I remember it is if you make a C with your index finger and your thumb, the C stands for cephalic. So then that means that on this side here will be the cephalic vein, and here will be then basilic. So if I just draw a line up like that, and line up there, this one will be then the cephalic, and this one will be basilic. Actually, in the forearm, I think they're actually ventral, so they'll be on the front, so kind of travelling up here and here. But just because I drew the dorsal digital veins and stuff, I'm just kind of continuing it. But yeah, I will then just draw them here as well because they're quite important. Like this. Okay. So then this one will be cephalic. And this one will be basilic. So, what then happens is you then have the basilic vein kind of keeps going up until it, let's say, this point, maybe. And then the cephalic vein kind of, it basically goes through between the deltoid and the pec major, so called the deltoid pectoral groove. And you can kind of feel it between your shoulder and pec major. That's where the cephalic vein goes. The basilic, if we say it cuts off at this level here, yeah, I forgot to say, medial cubital vein then just joins in with the basilic, and then the medial antebrachial kind of joins with cephalic. That's why it's the Y shape. They just join in and then go up together. So after the basilic, let me just actually move that down then. Like that. Then the basilic turns into the axillary vein. And then what was the order we said for axillary? So if we go up here, axillary, and then it goes to subclavian veins. So, and then eventually this cephalic kind of joins in like that. And then now it's the subclavian vein. Okay, probably noticing, what about the brachial? So this is where you've got the radial and ulnar, you've got the radial and ulnar arteries, you've probably got veins for them, and you do, which kind of like their radial vein, ulnar vein, they kind of go up together, and then they form the brachial vein, which then goes up and then kind of joins in the axillary vein like that. Yeah, so basically, in terms of learning the venous supply, cephalic and axillary are the most important. After the subclavian vein, what happens is it then goes to the brachiocephalic vein, which then goes to the superior vena cava. It seems quite long and confusing because I started, for example, at things and working the way up, but that's the way that the blood flow in the veins would work. For then simplicity's sake, okay, we'll go through it now. If here is heart, like that. Okay, we'll go from the heart and then working our way down that way, just to give like a really quick run through. Okay, so you've got the superior vena cava. So all of this blood is basically going to be getting dumped into the right atrium. Okay, so if we work backwards from right atrium, superior vena cava. From the superior vena cava, it's going to be going to the brachiocephalic vein. Here. From the brachiocephalic vein, it's going to be going to the subclavian vein. Subclavian vein basically then goes into the axillary vein. The axillary vein has two dividing points now, the cephalic and the basilic. So cephalic, make a C with your index and thumb, and that's the side the cephalic vein goes on, which means that the basilic vein goes on the other side. From the basilic and cephalic veins, they then lead down here and kind of create this dorsal venous network over here. Let me just change this so you can see it. Here, dorsal venous network. That's at the back of the hand. That then goes to form the dorsal metacarpal veins, which is here, and then that goes down to form the dorsal digital veins of the hand, which are there. On the other hand, you've got kind of this Y shape vein, I guess. The medial antebrachial vein and the medial cubital vein. Medial cubital vein here, going to be taking blood from. Medial antebrachial vein, going down here, then is going to divide into the palmar metacarpal veins and then the palmar digital veins. Hopefully that makes sense. But in terms of, it seems like quite a lot of detail now. Fair enough, it probably is. More detail than you probably need to know at this point. But you may be able to look back at this video and it might be helpful. Yeah, in terms of things to know right now, cephalic, basilic, because of the clinical relevance in terms of taking blood. The medial cubital veins are pretty solid one to learn. And then in terms of then just because of the reverse order of the arteries, ulnar, radius, it's quite helpful. And then like this, brachial, axillary, subclavian. And then obviously just going back to the heart. That I think, if when you're starting out for blood vessels, it's fine. And then you'll get loads of different branches and stuff. But hopefully that makes sense and I haven't confused you. Okay, let's go on to muscles. So I've tried to create a bit of a cheat sheet. Here, pretty much all of the muscles of the arm, forearm and hand that you need to know. Haven't spent that much time on doing the back. In terms of the back, the best way is to just go to the lecture slides. Actually, for all of the muscles, just go to the lecture slides. It tells you origin, insertion. There'll be blood supply. There'll be nervous supply. And actually what the muscle does in terms of its movement. Don't worry about learning all of that stuff right now. Try and get a big picture understanding of what's going on. Once you've got a big picture understanding of what's going on, then you can start learning the finer details of what muscle originates where and where it inserts and actually what nerve is supplying it and causing it to work. All of that stuff will come later, but just get an overview. So basically, the best way to describe muscles, if you have your arm in anatomical position, the front of your hand, all of that stuff, think of as flexion. So it's going to be reducing the joint angle. So, okay, if we start at your arm, and this is what I mean by arm, remember? If we work using our shoulder, so i.e. the deltoid muscle, which is this one here, we flex our arm, keeping it straight, we just move it forward. That would be flexion of the arm. That's there. If we now do flexion of the forearm, so we're basically bending our arm at the elbow, that is also then flexion. That's flexion. So we're using our biceps here to be doing flexion by bending our elbow, right? Deltoid does the whole arm when it's completely straight. Bicep, bending of the elbow. Then we're going here. So this is the forearm muscles. This does flexion of the wrist. So if you just keep your fingers straight together and then just kind of bend your wrist up and down, that up, kind of reducing the joint angle, is flexion caused by these muscles here. Then if you just keep your fingers straight together and kind of bend your fingers, so then there's muscles kind of in your hands and everything, they do that. And then what kind of causes your fingers to be able to bend at the different kind of PIP and DIP joints? Again, there are different muscles for that. Kind of all the way down there. You'll have intrinsic hand muscles and then different muscles in the forearm causing different movements. But what I'm trying to get the point across is all of this stuff at the front, flexion. All of this stuff at the back then must be extension. So what's causing you to straighten your arm out, or straighten your fingers out, or straighten your, bend your wrist back? These muscles here. So even something as simple as that, just try getting general rules as an understanding first, and it'll make learning anatomy way easier. Okay, we'll go to the back muscles because there's a few few ways that of little tricks that I found quite helpful when learning them, but you've still got to learn all the rest of them. So first one, serratus anterior. It's basically supplied by the long thoracic nerve. So if the long thoracic nerve is injured, where this is, it's basically like near the axilla. So axilla is basically near your armpit. That area, it kind of, if you put your fingers, like spread them out, that's kind of what serratus anterior looks like. Just, if you Google an image, you'll see that it kind of looks in that shape. What it's doing, it's also described as the boxer's muscle, because like boxers have a really big serratus anterior. What does that mean? What do boxers do? They punch people. So if you just do the punching motion, what you're doing is activating your serratus anterior. So then they're going to have like a really big serratus anterior. If that muscle is injured, it's actually attached to the scapula. So if the long thoracic nerve is like damaged in any kind of way, serratus anterior is not going to be working properly, which means then you're not going to be able to actually retract your scapula. So the way to test it is by pressing your hands on a wall in front of you, and then the scapula kind of goes up, and it's called winged scapula. So here, and that's just a sign for long thoracic nerve damage. That's like of clinical importance and like an easy exam question. Next one is the rhomboids. The reason I put these in, just the opposite of serratus anterior. Serratus anterior is punching someone. The rhomboids are rowing. So rhomboids row. So which means that you're just pulling your arms back. That motion is done by these ones here, rhomboids. So rhomboid minor is at the top here, and then this bigger one is rhomboid major. And yeah, that just does rowing motion. That's the dorsal scapular nerve. Here, big muscle kind of there, it's called trapezius. The reason I put this in is because it's supplied by accessory nerve. The accessory nerve is cranial nerve number 11. Cranial nerve number 11. The way to test it is activating trapezius. So just shrug your shoulders. You're activating trapezius. The thing with basically any upper body movement is very difficult to isolate, to do any kind of upper body movement without trapezius, because it's just in like every movement you can think of basically. Just look at the size of it. Yeah, then you got this other one just called latissimus dorsi. It's a big back muscle. Levator scapulae kind of makes sense. Levator, like elevate, and then the scapula, scapula. Yeah, you kind of just got to find all of the back muscles and just go through learning it. Yeah. Okay, actually going on to the arm now. So I said before that the shoulder joint it's easy to dislocate, right? It's a shallow glenoid cavity, which means that it needs stabilizing. And I said the rotator cuff muscles are one of the things that help stabilize it. So they're just muscles around the shoulder like that. What are they? The way to remember it is SITS. So supraspinatus, infraspinatus, teres minor, subscapularis. If I do like a really quick diagram like that, that's the scapula. So there, this one in the supraspinous fossa will be supraspinatus. Here be infraspinatus. On the inside would be subscapularis, and then teres minor. Is it on this diagram? No, it's not labelled. Teres minor is also rotator cuff muscles, not teres major. But yeah, so those are the rotator cuff muscles, stabilize the arm. You just need to learn those inside out. Next one is, then you've obviously got deltoid here. Deltoid is kind of divided into three parts. The anterior part, which is kind of like here. Then you've got the part in the middle, and then the part kind of on the back, which is here. So if you think about the front bit, does flexion of the arm, i.e. you're able to keeping your arm completely straight to move it all the way up. The middle bit allows you to abduct your arm, abduct, so taking it away from your body. And then the back, here, just move your arm back, i.e. extension of the arm. Okay, that's the deltoid. Going on to the arm now. So there's just some muscles here. So coracobrachialis, brachialis, biceps, and triceps. These ones at the front here, triceps, and the back there. Okay, I'm not going to go into detail with them, just get an overview first. Okay, so you got these forearm muscles, and then you got these forearm muscles. Difference between them is that these ones are here, and these ones are here. So what's the difference? These ones are here on the front. That means they are called the anterior forearm muscles. So what did I say with this side? This side does all flexion. Look at the names. Flexor, 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 flexor. Reducing the joint angle. This side, this does extension. Look at the names. Extensor, 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 extensor. They extend the arm. Okay, so if we just look at a couple of the names and break it down. So flexor carpi ulnaris. This is what I'm saying in terms of, if you understand a little bit of Latin, it kind of makes it a little bit easier in terms of figuring out what the muscle actually does. Flexor carpi ulnaris. Flexor, reducing the joint angle. Carpi, carpal bones, so wrist. Ulnar, so you know that there's an ulnar bone, the side near to your pinky finger. So that means that this muscle is probably going to be kind of around here, right? Because you know it's flexor, so it's the front. Carpi, so it's going to be kind of inserting some kind of carpal bone. And ulnar, so it's on this side. So that means it's going to be bending your wrist. Look at flexor carpi radialis, same thing, just radial side, like that. Flexor digitorum superficialis. Digitorum, digits, your fingers. So somewhere kind of around here, and now it's just moving, reducing the joint angle in your fingers. If you look at this, superficialis means superficial, profundus means deep. I said pollicis means thumb, longus means long, and then brevis means short. So here, for example, brevis is short. Pronator quadratus, that's kind of like a muscle here. Think of it this way, pronator, so it's pronation versus supination, so it's pronating your hand. Quadratus, the way to remember it, it is a square shape, which is why it's the quadratus. But if you can't remember that, because most of these muscles go like this, but as in quadratus is just a square like that. If you just kind of leave your arm hanging at the side, your arm kind of dangles at the side of your leg near the quadricep muscles. So then that means pronator quadratus, near the quadricep muscles, just down there. Okay, that's basically forearm muscles. Zoom in here. This is basically just showing some of the tendons. So flexor carpi ulnaris versus flexor carpi radialis, radial side, ulnar side. Flexor digitorum superficialis. Palmaris longus. Here, the thing with palmaris longus is that I think it's 15% of people don't have palmaris longus, but yeah, it's not deep. You actually don't need it. But yeah. Okay, so then after that, you've then got the forearm muscles that are on the back. That's these ones here, and then it's just kind of then going through each of the names. So you've got superficial layer, intermediate layer, deep layer. Then you've just got superficial and deep layer, like that. Then going on to the hand. The hand is a very, very, very complicated bit of equipment, and it gets quite confusing. So I've tried to simplify it as much as I can. But yeah, so thenar muscles, thenar, thumb, T and T. So that's going to be this kind of pad there, just below your thumb. That's where the thenar muscles are. Hypothenar is just the opposite side. So that's this side here. Yeah, if you just pollicis means thumb. So abductor taking away from the thumb, flexor reduces joint angle. Opponens, opposition, that allows you to touch your thumb to your fingers. And it's the same kind of here. Digiti minimi, small digit, pinky finger. So that's why hypothenar is going to be on that side. Adductor pollicis, palmaris brevis. These, like, sometimes you might see them as being into thenar and hypothenar muscles. Check the different sources. And then finger muscles. So dorsal interossei, palmar interossei, lumbricals. Dorsal interossei. The way to remember this is dab and pad for dorsal and palmar interossei. Dab, dorsal AB duct. So dorsal abductors. So what does that do? Abduct, take away from the midline. So then that means it separates your fingers. So it allows the gaps in between your fingers. Dorsal interossei, that's what they do. Palmar interossei, this is on the front of your hand now, as opposed to dorsal back. Palmar interossei, pad. They adduct, so adduct, bring your fingers together. So dab and pad. Lumbricals, what these do is they allow you to kind of bend your fingers at the metacarpophalangeal joint, but your DIP and PIP remain straight. So the way I kind of think of it is like the way a sock puppet hand moves is the lumbricals. Lumbricals actually is like the same word for like worms, but that's just a random point. Okay, so next, that's basically the hand and all of that sorted in terms of the muscles. Then you've got these kind of 3 images, which are just like little kind of tricks to help remember it, because this is a lot of muscles. And then with each of these muscles, there's an origin, insertion, nerve that goes along with it, action, and there's a lot. And I haven't even included any, like the back muscles, but this is just the arms. Here's just a couple of things to help remember it. Okay, so if we go with this one, if you just do this with your fingers, what happens is you will then see these kind of shapes will appear. So you have the triangular space, quadrangular space, triceps hiatus. So the triangular space contains the scapular circumflex vessels. These are just blood vessels like arteries. Quadrangular space contains the axillary nerve and the posterior humeral circumflex arteries. And then this one here, the triceps hiatus, contains the radial nerve and profunda brachii. Just doing that with your fingers is just an easy way of helping to understand. So that means this is happening at this kind of level around here. And then it just tells you what's going through what. Okay, going on to this one now. This one is a quick way of kind of remembering these muscles. Superficial layer of the forearm. So, oh, I forgot to say, with the flexors of the forearm versus the extensors, flexors all originate from the medial epicondyle, extensors from the lateral epicondyle. So, if you put your hand on your medial epicondyle, this is what happens. This is what you'll see. So your index finger is pronator teres, and yeah, kind of just goes across like that, and that's a good way of remembering it. There's another way, which is what I do. I just do my thumb as pronator teres. I then use my index finger, because it's already on the radial side, as flexor carpi radialis. I then put my pinky finger as flexor carpi ulnaris. For palmaris longus, I do the middle finger, because it's the longest finger. And then I do the ring finger as the intermediate layer, flexor digitorum superficialis, because it's the ring finger. And the way I remember it is people get married for superficial reasons, so hence the ring finger. So that means you're using all 5 fingers and you've learned an extra muscle. But you just need to be aware that, ironically, a muscle that has the name superficial in its name is actually an intermediate layer. Yeah, okay. This image now is for the anatomical snuff box. And so if we just match up each of these letters with what's going on, here is the actual anatomical snuff box, and it's formed by each of the tendons. So EPB and APL. So we go EPB, extensor pollicis brevis, probably, which is there, so it's a deep layer. APL, probably abductor pollicis longus, yeah, there. And EPL, extensor pollicis longus, there. So these are all in the deep muscles, which makes sense because all of the pollicis muscles are in the deep layer. Yeah, and that forms the anatomical snuff box. The thing with anatomical snuff box to be aware of, remember the carpal bones, the one that's near, you've got a scaphoid fracture. If you fall on an outstretched hand, you can get a scaphoid fracture, and then the anatomical snuff box feels kind of like squishy. The other thing, if an elderly person falls on an outstretched hand, that would be called a Colles fracture. But yeah. Okay, so going on to this thing. This is called the carpal tunnel. The carpal tunnel is this. Here. This is your tunnel. So here are the bones, the carpal bones, and here is the flexor retinaculum. It's basically like a sheet that just covers it. These are all of the names of all of the different muscles, blood vessels, etc. Well, tendons for the muscles. And yeah, so here's the actual kind of tendons for the muscles. This is what's important, the median nerve. If you get compression of the flexor retinaculum, the median nerve is going to get compressed. If the median nerve is compressed, you get carpal tunnel syndrome. What does that look like? Well, it's going to be on the medial side. The muscles that are supplied by the median nerve are going to look wasted. And which muscles are those? Well, we'll get into that basically like right now, because we will move on to the nerves. But actually, before we do, how do you test carpal tunnel? There are two signs, so Phelan's test and Tinel's test. Phelan's test is called reverse prayer sign, so Phelan, P, and then prayer, P, like that. Reverse prayer sign. So it's just putting the backs of your palms and your fingers together, and they like your fingers kind of face down. That's called reverse prayer sign, Phelan's test. And then you'll just feel pain. Tinel's test is just tapping on your wrist again and again and again, and you'll feel pain because of carpal tunnel syndrome. Yeah. Okay, so going on to nerves now. This is the last section. I know this is already a very long video, but yeah. Okay, so going on to the nerves. Actually, before we do, one of the important things I probably could have mentioned here is brachial artery. You can get this thing called a supracondylar fracture, which is break the humerus, and it's like causes a stringing of the brachial artery. But yeah, alright, now we'll go on to nerves. Okay. So, next one is just do like a little brief overview of what happens with each of these nerves. So, this bit here, this part of the arm, is called, like, basically supplied by, these are all like generic rules now. Obviously there'll be like exceptions, so like, half of this muscle is supplied by this nerve, 1/3 of this muscle is supplied by that nerve. This is for when you're literally like completely stuck in an exam, or when you're just starting off learning to get like a brief overview of what's going on. yeah, just a brief overview. So here, just think of this as the musculocutaneous nerve. So that's all of these muscles, basically, except for triceps. So just ignore triceps. These three, because triceps is on the back of the arm, so that's here. These three around here, supplied, for the sake of a generic rule, musculocutaneous nerve. Okay, so let's go on to the next one. Here, like that. The front of the forearm, median nerve. Okay, so that then is these. This is all supplied by the median nerve. However, you can look here, flexor carpi ulnaris. Why would a muscle that already has ulnaris be supplied by the median nerve? It's because it's not. It's supplied by the ulnar nerve, which is actually quite handy because it already has ulnar in it. Why? Well, that's because on the ulnar side here, it's going to obviously then be supplied by the ulnar nerve. Yeah. Okay, so then that's the median nerve, which is the front of the forearm. Now you've got the back of, then we'll go to the back of the arm, which is basically all of this. Basically, all of this radial nerve, back of the arm. And then if we go to the hand, now the hand is basically just supplied by the ulnar nerve. So I'm going to be quite careful in terms of how I colour it in. I'm going to colour it in like this. Like that. And this is ulnar. As you can see, I haven't coloured in the thenar muscles. The thenar muscles here, that is supplied by the recurrent branch of the median nerve. So yeah, the recurrent branch of the median nerve. That's basically what's going on there. And yeah, so then the hypothenar muscles, they are the deep branch of the ulnar nerve. So they still fit into the general rule of ulnar. And the same with the interossei, dorsal and palmar. So the DAP and PAD muscles, deep branch of ulnar. Okay, next, this is basically the last thing we'll go through is brachial plexus. What is it? Brachial. Okay, the brachial, if we break down this, what it means, brachial artery, brachial muscles, that kind of area, so like top of the arm there. Plexus just means like a network of nerves. So this is just saying there's a network of nerves that kind of come down the top of your arm, which is here. And this is forming the brachial plexus. The brachial plexus is just an annoying thing to learn. Best way to learn it, obviously, is not from a picture like this, because you won't be able to learn it. It's from a very kind of easily drawn out diagram. Best way to learn it, just draw it out again and again. Like this, or just stick in your head. Way I did it, so start off with the basics of just brachial plexus goes from roots C5 to T1. So here, and then you've got these are the roots, these are the trunks, these are the divisions, these are cords, and then these are the final nerves. So as you can see, musculocutaneous, median, radial, ulnar match up with musculocutaneous, median, radial, ulnar. And these are basically, the thing with the brachial plexus is that the brachial plexus is for motor nerves. So the thing with sensory is just learn the dermatome map, so dermatome down, and then that shows how you're being able to feel things. But in terms of movement, so actually moving your arms, brachial plexus does that. Yeah, and then just you'll see that. So this is the final kind of brachial plexus. It's obviously quite messy, but best way to learn it is just keep adding to it and just draw it out again and again and again. And it'll eventually stick. But yeah, don't take it all in at one go, because it's too much. And the thing is, you want to be able to get to a point where all of these nerves that sound like absolutely nothing eventually mean something, and you can associate, go, oh, okay, do you know what? I know that, long thoracic, it does this for this muscle. Oh, it travels around here. Superior subscapular does this. Axillary does this. Lateral pectoral does this. Medial pectoral. And start noticing patterns. So like lateral pectoral is on the lateral side. Medial pectoral is on the medial side. Medial brachial cutaneous versus medial antebrachial cutaneous. Antebrachial just means forearm. So it's just further down. Brachial just means higher up. So like where the arm is. Superior, middle, inferior. And just start noticing patterns. Phrenic nerve. Isn't that for breathing? C3, 4, 5 keeps the diaphragm alive. Yeah. And then you kind of just notice different patterns. And then that's kind of the best way to learn it. Okay. Now this is the last thing. See, there's nothing else. Brachial plexus injuries. This is like a really easy thing for them to examine you on. Kind of weird looking names. So herbs, klumpkeys. But yeah. What these do is they test your understanding of the brachial plexus. What you want to be able to get to the point is where you can look at a brachial plexus, or actually you don't even need to look at it, you just know it, and you can go, oh, okay, do you know what, at this level, there's some kind of problem. So if there's a level at C5, what would be affected? What would that look like? Because you know that if this isn't working, then none of this is going to be working. And if none of that what's going to be working, what muscles do these then supply? And from that, you can then figure out, oh, okay, that's why it looks like this kind of pathology or whatever. So, Erb's palsy, C5, C6, that's what's affected. This looks like Waiter's tip. So what Waiter's tip looks like is your arm is basically at your side, your palm is facing back, so it's pronated, and then your wrist is flexed. So it looks like you're looking for someone to just put a bit of money kind of in your hand as you're walking away, i.e. a Waiter's tip. The way you get this is from your neck bending. So your neck bending is because it's a higher up brachial plexus injury, C5, C6, as opposed to lower down, such as like klumpkeys, which is lower down C8 and T1. So this could be like falling and landing on like your neck or your shoulder, or in childbirth, pulling the child out from their head. Klumpke's palsy. So the way I remember it, Klumpke and claw. So k sound. Your hand looks like a claw because of the C8 T1 injury. This is caused by hyperabduction of the arm. So for example, if you're falling and then you just grab yourself on like a branch if you're falling from a tree, or during childbirth the child is pulled out by their arm, there'll be like a lower brachial plexus injury, which is C8 T1. Next one, Saturday night palsy. This is radial nerve, and this looks like a wrist drop. So this is, picture it as you've fallen asleep with your arm hanging over a chair, and that compression kind of at your armpit, that then compresses on the radial nerve, and your wrist just kind of looks really floppy. So the way I remember it is radial wrist. Hand of benediction. This is a medial nerve injury. So you get this thing called Pope's sign, like hand of benediction, like Pope sign. And it looks like, for example, if you're doing like a little gun kind of thing with your hand, your first and second, your index finger and your middle finger are straight, and your other fingers are bent. Oh, and your thumb's also straight. And it looks like a Pope's blessing kind of thing. The reason why that happens is because the median nerve is damaged, and that's what happens when you're trying to make a fist, but you can't because the median nerve is damaged, so those three fingers remain straight. Where I remember it is because popes can't fight, so they can't make a fist. And finally, ulnar nerve palsy. This is when the ulnar nerve is damaged, and the test is called Fromet sign. So if somebody asks you to like hold a piece of paper, if you just Google images online, their thumb is bent in a positive Fromet sign because their ulnar nerve isn't working, and it's straight when you're just holding it when it's not working. So this has been quite a long video, but hopefully it's been helpful in the sense that it's given a bit of an overview of everything before you actually start learning upper limb. Then you can watch this before you start learning it properly, and then after as like a revision, just to make sure you haven't missed anything. But yeah,